A pleasant good evening to the viewing public. My name is Dr. Varma Rambaran, an associate professor at the University of Trinidad and Tobago, or UTT. And I would like to welcome you to a very exciting and equally informative lecture entitled Assessing the Risks of the COVID-19 Vaccines. This lecture forms part of a 5-day webinar series that was made possible by the Office of the Vice President of Research, Academic, and Student Affairs, and is geared at educating you, the public, on the various aspects of the ongoing COVID-19 pandemic. It is being presented by our very own Dr. Nicole Ramlachan, Associate Professor in Biotechnology. Dr. Ramlachan holds a PhD in genetics from Texas A&M University, USA, and a BSc and MSc from the University of Guelph in Canada. She has extensive experience in research in the areas of genetics, specifically in the areas of immunogenetics, clinical genetics and genomics, bacterial and viral biotechnology, forensic DNA analyses, and molecular biology. Nicole has worked with the ministerial appointed DNA Committee for the implementation of the Administration Deoxyribonucleic Acid Act 2012 in TNT. She's involved in genetic testing locally, including SARS-CoV-2 virus testing, research, and is certified in ISO IEC 17025 testing laboratory standards. She has spent the last 25 years doing teaching and research in 7 countries, in academia and private companies, as well for the US and Canadian federal governments and international agencies based in South and Central America. Dr. Ramlachan was also involved in the sequencing of the bovine and caco genomes and is well published internationally. She also has had tissue culture experience and has worked on virology and microbiology projects with research models studying bacterial and HIV retroviral infection, as well as the production of monoclonal antibodies. In addition, she has set up laboratories in Trinidad, Guyana, and Latin America. She also holds memberships in several international organizations and has given invited lectures internationally. Please be reminded that you can send in your questions to Dr. Ramlachan via our YouTube page. So, ladies and gentlemen, without further ado, let me welcome to our virtual platform, Dr. Nicole Ramlachan.
Thank you very much, Dr. Rambaran. Welcome to the public. I am very excited to do this episode. Because it's going to really answer, I think, a lot of the questions that we have and everybody's been asking me to address. So in terms of what we're going to talk about today, I mean, it is a series, so we're kind of going in sequential order, but the session 3 is basically COVID-19 vaccination and what are the risks. And we're going to deal with a little bit of the myths and truths and do a little myth buster kind of session because I believe that that's probably the most effective way to kind of get the answers that you guys have. So just to update you all in terms of what's happening in Trinidad and Tobago, everybody would have probably seen or heard of the Ministry of Health and Prime Minister's talk today and what they were doing in terms of updating the public. We've gone into a little bit more of a lockdown because of this sharp little increase here. If you notice, it's pretty high in terms of the peaking. As of the 2nd of May, there were 241 new cases. So if you look back in terms of what we saw last year, we're actually higher than we ever were. So we are definitely upwards of 2,373 total cases between that period of time of 19th of April, 2nd of May, which is the highest that we've seen so far to date. In terms of vaccination, we were vaccinating, most of the vaccinations that we did were in April, started in February with a first set of 2,000 doses from donated to us from Mia Mockley in Barbados, COVAX selection, and then we got our own first delivery of the COVAX tranche, which finished up last week, and then now we're secondly in our second tranche of 40,000 from India that we've just now started today. So you notice it's kind of flattening off a little bit. In terms of numbers, we're right roughly at about 40,455 as of today. No one's fully vaccinated, if you notice that on this little blank line here means nobody's fully vaccinated because we've only received roughly our first doses. Some of the healthcare workers probably would have received second by now, but the numbers are negligible compared to the total population. So just to remind you, the whole story of COVID-19, of course, is how do we attack it? How do we stop this pandemic from continuing through the process of treatment and vaccination and getting herd immunity up to a certain level, right? The idea behind that is that we're trying to attack the COVID-19 during the chain of infection to interrupt this process. So generally, we have the reservoir. That's where we would have gotten the first viruses from. And of course, us as hosts now that we've mutated into this form of COVID-19 and continue to mutate in terms of the viral mutations and who it affects and who it doesn't affect. The portal of exit, how the virus actually leaves the reservoir of the host, modes of transmission, person to person, all of that. Portal of entry, again, how does it get back into the additional person that or animal that it's infecting, and then of course it's going to affect the susceptible host person more and then become infectious and so on and so on. So the idea behind prevention is to interrupt this process, and how we do that through vaccination is that we either stop how it reproduces, we stop how it enters as any portal of entry, or we can stop the modes of transmission. So we're trying to reduce physical modes of transmission. That's where your mask wearing is coming. You're reducing exposure to individuals. You're 3 to 6 feet away from people because it can be spread directly, either airborne or direct contact with the virus on a contaminated surface to a lesser extent. But you want to actually continue to be doing that mask wearing, keeping a distance, not being crowded areas, being highly ventilated, open door, outdoor kind of areas, because you are trying to stop that physically. The vaccine comes into the entry and the replication process, where we're trying to interrupt that process for the virus. If you remember from our previous talks, where we talked about the potential vaccines that are available and what we're actually doing, just to touch it on briefly, the mRNA vaccines like the Pfizer and the Moderna are packaged into fat molecules called liposomes, lipid nanoparticles, and it's literally pure mRNA. So it has to bypass all the mechanisms usually that we would usually have to use, and it can go straight into the cell cytoplasm and be harnessed into a viral protein making machine via the cell, which now pumps those out, and your antibodies can respond to it, and the antibody producing cells will remain in your body on a long-term basis, hopefully, and provide extended immunity, right? The adenoviral vector, same concept in that the mRNA is what we're using. However, we're packaging it differently. We're putting it into viral vectors. And this would be the Chinese vaccine, AstraZeneca, Johnson & Johnson, where we're actually utilizing the viral vector as a transmitter of that mRNA into the cell. Same thing, it bypasses the nucleus, goes straight to the cytoplasm, comes out as viral antigen after it's encoded and translated by the cell. And then now it's repackaged and presented to the antibody producing cells, which will attack it, hopefully give us memory cells and have a long-lasting immune response. That's a plan. The DNA vaccines that are coming out of Canada and a lot of places, they're using the same concept as the mRNA. They're packaging it into lipid nanoparticles to limit that need for a carrier. And it's actually exciting because they want to deliver that vaccine either as a nasal spray. So for people who are, again, prone to not wanting to be stuck with needles, that would be exciting for them. But it's a little more effective as well, too, because it's going directly to the lung area respiratory system and attacking well, not attacking, but try to promote a response at that point. And then it's the same concept. The DNA goes into the cell's nucleus at this point, and then is translated into, transcribed into mRNA, translated into viral protein, which is then, of course, presented to the immune cells, which will then have a long-term antibody producing response. So similarly, the same concept all the way through. Again, I just wanted to remind you all, the numbers we're looking at really is the hospitalization and death prevention. People constantly ask that question, what is the best vaccine to take? Basically, the vaccine that's offered to you. That's what I constantly say, because you're going to get 100% protection from death and hospitalization, because that's what we're looking at. That's the magic number. As we look at the coronavirus vaccinations around the world, we are at a little bit over 1.1 billion right now, actually. And it's equal to about 14 doses for every 100 people. But of course, there's a big gap between the different countries, with the richer countries, the top 10 countries actually having 75% of the vaccines versus the less developing countries and the poorer countries who weren't able to put out as much money up front. There was also a little bit of hoarding going on there that we discussed last week. But anyway, so the idea behind it again is that the viruses cannot replicate. They need to have a host. And basically, the vaccine is going to actually prevent the virus from replicating by allowing our body to attack the viral antigen as soon as it sees it. As soon as it sees the viral antigen, attack the virus, and thereby actually defeating that self-replicating tendency that it tends to do, to be able to harness our machinery to do it. Examples of vaccine preventable viral diseases would be like mumps, measles, rubella, influenza, hepatitis A and B, and a lot of these are boosters and are 2 and 3 vaccines. So we are used to it. We used to being able to have to give 2 or 3 doses in a schedule. All of you all with children all of you all who were children would remember that the vaccination schedule is usually given over a period of time. The influenza is the only one so far that we've actually had to give every single year. And that's because, again, as I recall last week, we talked about the antigenic nature of the virus, right? It changes so much that we can't account for all of the different variants that are in circulation in that particular year. So we usually have about 3 to 4 variants per vaccine per year, right? And again, the efficacy of the influenza virus vaccine, because we have to spend 2 years actually producing it, we have to predict what's going to happen 2 years ago, right? And sometimes we're hit, sometimes we're missed. So vaccine efficacy, when it comes to influenza, we used to write about 30% being great, right? Because sometimes we miss completely and we get 5 to 10%, and it's not effective. And SARS-CoV-2, of course, is our RNA virus, right? Now, the P1 variant that everybody's hearing about has been verified in Trinidad. Last time I did this talk a couple of days ago, last week, I should say, it was not, but now it's actually been shown to be present in 54 countries, including Trinidad and Tobago, as verified, right? So we have it here, and at least from what we know, 15 cases, I believe. Sequencing is a little slow. We hope to get that up a little bit, because that's the only way for us to know what variants are here. But they're right about, I think, 10 to 15 now, I believe, has been confirmed. What is our status? We've had 2,000 donated by Barbados to frontline workers. About 33,600 arrived on March 31st. About 40,000 came shortly after directly from India. And about 100,800 have to still be received through the COVAX order by the end of May 2021, right? We're pretty slow still on our vaccination rate. We need to get those numbers up. So we need to have buy-in from the public. We need to have the government of Trinidad and Tobago sourcing supplies. We need to have a all hands on board kind of attitude when it comes to the vaccination program, right? There are vaccines available from many different areas and companies. Sinopharm, Sinovac from China is also one. We talked about the specific vaccines and the makeups and so on yesterday as well, last week as well. But there are different components to all the different vaccines in different ways that they're made, but they're generally as safe as each other are, and they're generally as effective, especially at the 100% at keeping away the actual severe disease and death, right? Who should not take it? Anybody who has allergies to any components of the vaccine, anybody who's had previous anaphylactic reactions to drugs and vaccines, anybody under 30, low COVID-19 risk individuals that have other options. So that would be the recommendation for AstraZeneca and Johnson & Johnson in particular, just because they seem to be showing more of a clotting risk in individuals under 30, right? However, once the risk has been evaluated in terms of whether or not you are on HRTs, whether or not you are on immunosuppressive drugs, whether or not you are on birth control, those kinds of things, you can assess that with your doctor and determine whether or not you can take it. It is recommended that you take whatever vaccine is offered to you if no other options are available other than AstraZeneca. Pregnant or breastfeeding has been approved for Pfizer, still in trials with the other vaccines, under 16-year-olds, still in trials I believe it's Pfizer still and Moderna doing the 12 to 15 right now. And then, of course, individuals who are at risk for clotting disorders are not advised to take the vaccine, right? Are they safe? Well, there's this rumor that vaccines are causing deaths. In Israel, there are 16 out of 700,000 people that were fully vaccinated, right about 0.002%. That had COVID, so they're very effective. This was early studies. Of course, now we know it to be about AstraZeneca in particular is about 84% effective. Depending on what country you test it in, you get a different rate. The Chinese vaccines, we don't have much information on. Pfizer and Moderna are right around 98%, 97%, and Johnson & Johnson is right around, I think, 85%. Again, very effective, right? And most importantly, 100% effective against hospitalization for severe disease and death. How many people have actually died associated with vaccinations? Well, much more than that, actually it's a little bit more than it. 75 million people in the UK have already received at least one dose of the coronavirus vaccine, and they've only associated about 10 deaths directly attributable to the vaccine that they know of. The US is much more, 246 million have received, and it's less than 20 as in directly associated with the vaccine, right? They've had probably about 5,000 deaths total, but not all of them have been attributed to the actual vaccine. What are the normal side effects, right? People have all kinds of different ranges in terms of the side effects they have. Some people have mild and short term. Some people have a little bit worse and long term. It may include tenderness, swelling or redness at the injection site, headache or muscle aches, joint pain, chills, nausea, vomiting, feeling tired, fever, and they're very common. They're associated with many vaccines, including coronavirus vaccine. And if you feel uncomfortable, you recommended that you take paracetamol, right? That's the general treatment. They can also cause other kind of side effects. For example, they can affect your test results. This is a little image here of a very enlarged lymph node post-vaccinations of an individual. And it can last, usually these swollen glands can last about 10 days. If it lasts any longer, then they recommended that you see a doctor. If you're due for a breast screen, you need to mention that you have a vaccination and wait at least 6 weeks, because this can affect your test results, right? For things like mammograms and those kinds of things as well. Who should get vaccinated? Well, this is directly from the WHO. Individuals who have increased risk of severe disease, hypertension, diabetes, asthma, pulmonary, liver, kidney disease, as well as chronic infections that are stable and controlled, are all very good candidates for the COVID-19 vaccine, whichever one is available. They've been tested on these individuals and they are effective. They were tested also on immunocompromised individuals. Further studies are being done, but it's recommended that they take it, obviously upon advice from their doctor. HIV individuals as well too are very, very high risk for severe COVID-19 disease and death. So it's recommended that they take it as well too, because they were included in the clinical trials, and it's very effective with those individuals. Vaccination can also be offered with people who've had COVID-19, but they can probably defer their vaccination from anywhere between 2 weeks to 6 months because of the timing or the supply of the vaccine as well too, right? It's not been studied, all the vaccines have not been studied in pregnant and breastfeeding women, but it's recommended, I believe Pfizer has already, but generally we have to go with the SAGE advice from WHO as more and more data keeps coming up, right? And of course, it's not recommended in children under 16 as yet, because those studies are still being done. How protected am I until my second shot? A lot of people have been asking that question because of the length of time between the 2 shots. We've had 1 shot now in Trinidad, some of us, and people are wondering how protected are they? Are they able to walk around normally? Those kinds of things. In the Lancet, they did about 23,000 vaccinated healthcare workers, and they found that the Pfizer BioNTech vaccine was at least 70% effective at preventing COVID up to 3 weeks after the first dose, which was very good. They didn't expect it to be that good, but it was. Another study in Scotland, about 1.3 million people, showed that the Pfizer shot was more than 90% effective preventing hospitalization due to COVID 4 to 5 weeks after the initial dose. So it keeps you out of the hospital, keeps you alive, even the 1 dose, right? Will I still get COVID after my first dose? So let's just kind of go into the myths. More and more people are asking this question, and the idea is that no vaccine is 100% effective, right? So you're going to always have a certain percentage of cases of what we call breakthrough. This study in the Imperial College of London found that a single dose of the Pfizer may not generate an adequate immune response to protect against all variants of concern, which is another issue, especially with the P1 variant we have here. AstraZeneca, lucky for us, does protect against the P1 virus from studies from Brazil and other countries around the world. Of course, more and more studies are going along, right? Now, the study that they did here was based on healthcare workers, and of course, that was preliminary. But the efficacy is usually between about 50 to 70%. It's not certain that you're going to get it. There's a risk that you might get it, especially if you have a breakthrough, but it's not certain 100%. You have a certain degree of protection. Right. Next myth, you can get COVID-19 from the vaccine. Right. You can't get COVID-19 from the vaccine because it's non-infectious. As I explained to you, it's made up of the nucleic acid of a very small piece of the spike protein, right? None of the approved vaccines contain live virus, and it means that COVID-19 vaccines cannot make you sick with COVID-19, right? You cannot get it. It cannot happen. It is not physically possible to. A person can get infected with SARS-CoV before or after vaccination and still get sick because the vaccine has not had enough time to provide protection or work. It takes a few weeks for the body to actually build up immunity, right? So that is possible. And of course, experienced side effects also is possible. And it usually means the vaccine is working and the immune system is responding. And as I keep on saying over and over again, it's good that you have side effects because it means that you're actually getting a response, which is what we want. And you may have long-lasting antibodies, which is what we want. What is the risk of breakthrough? Well, we mentioned breakthroughs before. So far, there have been about 5,800 cases of breakthrough COVID-19 infection in fully vaccinated individuals, 78.5 million. So it's right around 0.0075 or 76%. I rounded up to 8 to just kind of give you the benefit of the doubt, but it's very, very low. So this is in line with expectations of approved vaccines for other diseases, and they're very highly effective, right? But as we say, they're not 100%. It's usually about 99.88 whatever percentage, whatever that is minus, I can't do math, minus 0.0074, but they are very highly effective. And there's always a reminder that even vaccinated people who are at risk should continue to take precautions, such as masking and social distancing, right? The myth is here that what if I don't get my second COVID-19 vaccine dose on time? This was a big concern because, of course, with the shortage of vaccines available to everyone and the schedule that we have, a lot of people are worried that they're spacing out their doses too far. We have actually found in studies that extra time can help. It actually improves the vaccine effectiveness because the antibody response gets to actually have a time to actually come back in. And it's recommended now that AstraZeneca in particular and some Pfizer and Moderna in some countries not be given beyond between more than 3 to 4 months apart, right? So Canada is actually recommended 4 months apart. So it's okay to space it out from what we know, right? And from the efficacy of it, right? Some people feel that there are more side effects with AstraZeneca. Is that really true? The answer so far is no. There's no evidence per se to support that AstraZeneca specifically has more severe side effects than the other mRNA vaccines. You still get your pain, itching, feeling tired, chills, fever, headache, nausea, muscle pain, and joint pain, which are very similar to the ones reported with Pfizer, Moderna, and Johnson. What we're seeing is that younger people are getting faster and stronger immune responses sometimes, so they report more, but that's because they have more stable and robust immune systems than the older individuals. Transmission of COVID-19 is greater after the vaccine. A new preprint study from Public Health England, which has now been peer-reviewed, found that 3 weeks after a single dose, the household transmission was reduced between 39 to 49%. So that's fantastic news. So if you have several individuals living in a household, only 1 or 2 have been vaccinated, you can expect that the transmission from that individual to be able to bring home and spread that disease is down about, somewhere between 39 and 49%, right? And it actually suggests that just after the first dose, it significantly reduces the spread of the virus and the severity of the disease in those who do get infected, which is great. And it goes to show why initially the first dose is as good as it is, because the better strategy is to go spread out that first dose as far and wide as we can to get good protection against transmission. The vaccine does not protect against new variants. We touched this last week. It shows good efficacy against the Kent variant and as well as the South African variant and the P1 variant. And it seems to protect vaccinated individuals in Brazil and India against the variant. So I think that's an easily busted myth. Can the vaccine cause infertility? Well, no published evidence has been shown to show that there's this cross-reactivity between the S protein and the succincting one placenta protein, right? Women, however, who have contracted COVID-19 have actually had infertility risks, have had miscarriage risks and those kinds of things, but not infertility, right? If it is that it was causing a problem, we would have seen everybody across the board, even people with COVID-19, having it because they also have been exposed to the S protein, which may have caused this supposed purported idea, right? So there's no reasonable basis to believe that vaccines will affect fertility in females at all, and that can be debunked. What about erectile dysfunction in males? Again, COVID-19 infection does cause erectile dysfunction. However, the vaccines themselves have not. So if you want to prevent erectile dysfunction, you should get COVID-19 vaccination, right? Sperm count and male fertility also has not been shown to be affected by vaccination, but these have also been shown to have a lower sperm count with COVID-19 infection, right? So COVID-19 infection causes ED and low fertility in males, but not the actual vaccination. There's also a myth that only one shot of COVID-19 vaccine is needed. No, the first shot of the 2-dose coronavirus is giving you only partial protection. The analogy is like if you go to elementary school and you educated up until standard 5. The second dose will broaden you back to university level, right? So when your first shot sends up a battle cry, tells the immune system start to produce antibodies, but to get the really good immune response that's long-term, you need to get additional memory from the second vaccine, right? So the quality of the immune response after one shot is okay, but not as sophisticated and as long-term as we need for the second shot, right? So one shot allows you some immunity, but we need the 2 shots. Do vaccinated individuals shed? No. Just frankly, no, they don't. It's not possible for you to shed COVID-19 if you're vaccinated. There are people saying that they don't want, in Miami, saying that they want to reject vaccinated teachers because all kinds of craziness. I just want to say no, not true, can't happen, right? Because you don't actually have the virus if it is that you've been vaccinated and you can't shed it. Vaccine kills more people than COVID-19. That was an interesting one I heard. The death rate among COVID-19 vaccinated people is significantly higher compared to unvaccinated population. We know that's not true, right? In fact, they actually bothered to do a study, and people who were 65 or older were 94% less likely to be hospitalized, and 64% less likely if they've only even received 1 dose for the mRNA vaccine. Can vaccines disrupt your period? I told you all last week I was going to touch on this one, and there's no evidence that vaccines disrupt the menstrual cycle. No possibility that a vaccinated person can affect your menstrual cycle by shedding vaccine on top of you can't happen, or shedding antibodies on top of you can't happen. Whatever you injected in, or whatever the vaccine ingredients are, stays in the body of the person that's vaccinated, right? And cannot disrupt your period if you're exposed to a vaccinated person. What about the mixing and matching vaccines? There's a lot of people who are concerned when it is they say they're taking AstraZeneca from here and they're doing it second shot from another place and so on. If it is you within the same manufacturer, it's not an issue. There are a couple of studies that's actually going on now that they want to actually mix because they feel that they're be much more flexible in terms of their rollout. And a lot of vaccinologists feel that if you get a different type, because remember they have different types, that you can actually get an immune response that is going to be additional to the one that you have, especially with the variants of concern. So this would be people who've gotten Pfizer and Moderna, who now are exposed to P1 and some of the other variants, and which are getting a better coverage with AstraZeneca, who might want to take the AstraZeneca, and they're doing those studies now to see if that could be done. Right, so the blood clots, I needed to address the blood clots. As of April 20th in the European Union, there have been about 287 reports of rare blood clots with low platelets after administration of the AstraZeneca, 8 with Johnson & Johnson, 25 with Pfizer, and 5 with Moderna. So the clots are notable because, of course, they are in either the CVST or other areas that's deadly, right? So the risk of developing a serious brain clot or CVST is higher or was higher from what this is that they see, 8 to 10 times people with COVID than those who get a vaccine, right? So that is a really high risk, and other types of thrombotic events as well too. It estimates that while these blood clots are uncommon after COVID, that there's 39 in every million people developing 1 or 2 weeks of being ill, which is much rarer than a vaccine, which is usually at about 3 or 5 in a million, depending on who you talk to. What does the data show for all the vaccines? Clots are common in people who already had cardiovascular disease. 80% of the people who had clots survived. Some cases were seen in the under 30s who were not immune to serious complications from coronavirus, but they also had other issues like either taking, especially females, taking birth control and those things that raise their risk. Smoking raises their risk, all of those kinds of things. In those who had an mRNA vaccine, the estimated of the CVST occurred right about 4 in a million. And so far, they are not conclusively saying that they're linked, but there is a risk of clotting with all vaccinations generally. And they're continuing these studies on it. But right now, they haven't paused AstraZeneca or Johnson & Johnson in any country. They're being used all the way through. So just kind of show you when we talk about risk, COVID has about a 16.5% risk of these blood clots. Smoking has about 0.18. Taking birth control and Viagra is right about the same thing, usually about 0.05 to 0.12. And AstraZeneca is about 0.0004. Right? So it's a very, very low risk. If we look at it graphically in terms of this break it down any types of clots, the CVSTs, very high for COVID-19, about 4.1 for mRNA vaccines, Moderna and Pfizer, normal influenza kind of nil, and AstraZeneca right around 5. And if we look at the portal vein thrombosis, which is another event that can occur with COVID, much, much higher. This is events per million people in 2 weeks that we've reported. mRNA vaccines right about 44.9, normal influenza virus infections 98.4, and AstraZeneca vaccines about 1.6. So pretty low in terms of rare risk of clotting with COVID-19 vaccines, right? And they've also recommended for individuals 18 to 29 years, if you've already had one dose, complete the second dose and complete the course, especially individuals who are carers of the immunosuppressed and the elderly and those kinds of things. What about children and pregnant women? We touched on this. Initial trials were done initially on other individuals. We're now expanding those. Eventually, every single demographic is going to be vaccinated, right? For now, pregnant and breastfeeding have been approved for Pfizer. The rest of the vaccines are coming on board depending on what happens with their clinical trials. But eventually, children will be included. They would have to be because they are both affected and carriers, right? Right now, there's a pretty high risk of COVID-19 to children that we're seeing, and with the different variants, or higher risk, I should say. There is an increase in individuals passing from COVID-19 under the age of 18 in India and Brazil, and also the US, right? And some in Canada as well. So it is killing more children and youth, probably because the individuals around them are vaccinated. There was a 13-year-old Brampton girl that died after contracting COVID-19, and there was a boy who flew with his parents to Hawaii, who were both vaccinated, who died yesterday as well too. So it is actually affecting children, right? In terms of the vaccine doses per 100 people, just to kind of show you where we are, we're right at the bottom here. So countries like Bermuda, United States, all of these guys are higher than us. We have to get on board and get in a better position for our vaccination protocols. The vaccines are safe enough to take based on the data we have. However, you can reduce your risk. How can you do that? You can take antibody testing to look at your status. You can do genetic testing for thrombophilia and related conditions. You can test for vaccine-induced immune thrombocytopenia, VIT, which is one of the ones that causes the CVSTs and those kinds of things. You can even do platelet-4 antibody testing to determine your personal risk at that particular day. And of course, you can visit your doctor at any point in time to assess your personal risk and discuss your case and your risk with him. Final take home, as always, get vaccinated, get vaccinated, get vaccinated. That's the only way for us to end this, get out of this pandemic and move on with life. Thanks for having me in your homes and on your phones, and looking forward to sharing a good debate.
So thanks a lot, Dr. Ramlachan, for that very informative discussion. At this point, I would just like to quickly recap some of the salient points that, that were discussed in today's webinar. First one, the initial dose being followed by a timed booster shot is nothing new. You made some references to measles, mumps, and rubella vaccines and others that we would have been subject to as in our infant phases. So those of us who are casting doubt in terms of why we must have a second vaccine or a second shot, it is recommended that you take your follow-up shot to maximize your protection. Right now, you confirm that Pfizer and Moderna are going through their final phase of testing for patients 12 to 15 years of age, and that will be soon approved and ready for administration to the general public. You touched as well on the point of who should get vaccinated, apart obviously from the obvious answer, which is everyone. You stressed on patients suffering from non-communicable diseases, especially as well. Well, this in this case would be a communicable disease, which is HIV positive patients. They especially are highly susceptible to any sort of unfortunate endings if they contract COVID-19, and definitely if you are HIV positive. To the general public, Dr. Ramachan definitely recommends that you go and get vaccinated. It was very heartening to hear that the AstraZeneca vaccine that is available to us actually protects us against the P1 variant. And so for the many naysayers who are attacking the AstraZeneca vaccine and saying that they would prefer the Pfizer or the Moderna, we actually have something very good in our arsenal, especially as it is in our population right now. You cannot get COVID-19 from the vaccine, people, all right? So remember, Dr. Ramachan said so. There is a 0.008% chance of a breakthrough after vaccination. It does actually satisfy the claim that no vaccine is 100% effective. However, that very small percentage is still something that goes in favor of being vaccinated than relying on your natural immunity. You also stressed as well that it is actually recommended to delay the booster shot, citing that that some countries are pushing for 3 to 4 months to get the booster shot. So the more it is spaced out, the more effective your protection will be. You also as well touched on the point that the vaccine cannot run the risk of infertility or erectile dysfunction, and as well it cannot affect your menstrual cycle. And finally, a very good point is that just in case that we may not be able to get the exact vaccine that we would have initially gotten as our first shot, there are presently studies being undertaken to look at a mix and match technique. And in this way, in some cases, they're actually finding it more advisable because the patient's actually getting a wider level of coverage against different strains in which they were tested on. I have a question here from Kiran Bibaki. For those who want to wait on the Moderna and Pfizer, is it possible that we will ever get those vaccines available to us? Dr. Ramachan?
Moderna and Pfizer is hard to distribute in tropical countries because of the cold chain requirement. It requires storage at -70 to -80 degrees in the long term and -20 in the short term. So it's not impossible, but it's very difficult for us to both receive and transfer those vaccines around the country. So that's number one. Number two, they're in shortage in terms of production right now, in terms of individual countries who've already bought them out and the supply chain. So that's the two things that will kind of affect our supply of the mRNA vaccines, because those are the ones that are in the lipid nanoparticle storage unit that allows them to disintegrate very, well, not allows, but creates a situation where they disintegrate at lower temperatures very rapidly, and they wouldn't survive very well. So transport is an issue, and of course, obtaining them is an issue. So I'm not really sure how readily we're going to get large numbers of those vaccines if we're going to get them in the short term.
Okay, thank you very much. We have another question from Mark Neil Lewis. What are the precautionary measures to be taken immediately after vaccinations regarding alcohol consumption and any other that we should be aware of?
Okay, so thanks for that question, Mark Neil. That's a student from St. Vincent. hope that the volcano situation is kind of calm down a little bit there. I'm glad that you asked that question. A lot of people have actually asked me that as well too. It's the same recommendation with any treatment in that you should not consume alcohol for a couple of days after, just because you don't want to limit your antibody response. You don't want to create a situation in your body where your immune system has to fight something else off, or it be immunocompromised in any way. So you want to not really go on a hike or go to the gym or do any kind of stressful, strenuous things, or expose yourself to any kind of big issues, right? Like that. So vaccine, alcohol and vaccines don't necessarily go together. So I would recommend that you hold out for at least a couple of days right after.
Okay, thanks a lot. Another question from Kieran Babaki. Where can I get tested for risks and antibodies? And when would be the most ideal time to get these tests done? A week before vaccination or shorter?
Okay, great. That's a great question. We actually do it at Genetics Diagnostics. A lot of labs do it. A lot of doctors are doing it as well too. It's just a quick little pinprick of 1 drop of blood on a little kind of cassette, and you get results in 15 minutes, specifically for the COVID antibody testing. And that will give you your present status. And usually, as I said, you get your results within 15 minutes. You could actually even do it same day if you have your vaccination appointment. You can do the antibody test in the morning, or very close together, so that you can get that your status and be able to determine whether or not you should get your vaccine right away or wait a couple of weeks. Similarly, for the RT-PCR testing, the antigen testing, and all of those things, they're available all over Trinidad.
Okay. And before I close, I had one question of my own. I know you're just dying to actually hear my question. In your first slide, you put up a graph showing the amount of vaccinations that were done over the period of time. Now, the Minister of Health was preaching, trust the science. And we know that the first tranche of vaccines was sent out to medical or healthcare workers. And we see that the gradient was actually very steep, meaning that people actually understood what the vaccines were doing and how it was actually very helpful. The second batch, I noticed that the first couple weeks going into months, it was very slow. And do you think that this was due because of the public skepticism and the fear that was going on with these vaccines, especially due to the alleged the 2 alleged deaths that had occurred? Because clearly, another thing before you start answering, it seems as though the public were looking for guinea pigs, because coming down to the end, then the peak almost resembled the first tranche, where it started to get very steep and people realized that it was actually safer. This is my assumption, to take it than not take it. And this is why now there's a big rush for the vaccines. So do you think that if the other, like as you mentioned, and as the Prime Minister mentioned, we are looking at Sinopharm coming in and possibly Moderna. Do you think when those come, we will actually see that same sort of skepticism, or know that people now start to trust the science, we can actually see a continuation in the rush or the interest of getting vaccinated?
Well, it's two things there, right? First is availability and education, which comes from the Ministry of Health and the health agencies. And I believe they did not do as good a job as they needed to do initially in the beginning, in part because we got a donation very quickly through Mia Mottley's government in Barbados, and it kind of like was given to us like, bam, here, take this. And it was really for healthcare workers. And at that point in time, people weren't even realizing, well, vaccination was happening now or could happen now. And I think they needed to spend a little more time on the education, which is one of the reasons why we're doing this at UTT. And I am doing this personally because I feel that as a scientist, the word of the science is really, as you say, you need to trust. And if scientists aren't there saying, okay, well, this is how it is, really and truthfully, truly, there's no, risk, then there's going to be a very low buy-in, right? And that is what was happening initially as well too, is that we're not seeing the buy-in that we need to see because of the lack of education, the lack of knowledge, lack of information. The graduates from the University of the Internet and, Dr. Google, who advises everyone. And if the information is there, you just have to know where to find it. The other thing, of course, too, is the lack of supply, and that kind of comes into that curve a little bit, and the rollout. Our inability to be able to roll out. So if you notice, it's kind of flatlined over the last 2 weeks, because when the first tranche kind of petered out, we didn't know what to do. Everybody was like running around with their tail, between their legs, going what to do. I mean, you had 40,000 vaccines in the fridge. Start to use it. There's no confusion in that, according to, as far as I'm concerned, because all of these vaccines have an expiry date. So you must use them before they're expired. And we got those about a month ago. So they're coming down to their expiry dates, and they need to be used. Also, coming down to the end, I think why you saw that little peak is because that's when they started the mass vaccination sites to try to pump out the last of the first tranche before they expired, and to try to kind of bring that. So a lot of that is not necessarily lack of buy-in or things like that. A lot of that is just basically lack of making appointments, lack of people being able to actually reach the vaccine, to be able to get it, those kinds of things. So, I mean, with any kind of vaccination rollout of this size, this has never been done in the world. Never been done in our time, in recent times. And so this is a first, especially for Trinidad. I mean, they're going to have teething issues. People shouldn't be, take it personal. If you have a appointment and you reach to the place and they have no vaccine for you, people are getting severely offended and are personally affronted. It's nothing like that. It just means that they miscounted the vials, or they open vials too early, and they had to use it out before the vaccinated appointment people came in. It doesn't mean that you're not going to get it. You'll get it. Just have patience, right? This is something that has to happen. People have to actually buy into it, and I would say be patient. But at the same breath, hurry up and get your vaccine, all right? And hurry up and demand it as well from your government.
Yeah. Thanks a lot. We have one more question. I think you answered this already, but just for the benefit of the viewer, this is coming from Tunika Brewster. People who are vaccinated already, do they have immunity against this new strain, or would they need another vaccination?
Right. The new strain, as in which new strain? Because there's many new strains, right? So there's a double mutant in India right now, wreaking havoc. The one that we have in Trinidad is the P1, right? I assume that's the one you're talking about. The individuals who've been vaccinated really would have immunity to a certain extent to all the vaccines. AstraZeneca in particular has been shown to be effective against the P1. Okay.
So in closing, I would like to thank you all for logging in and being part of this very informative webinar series. And I'd like to invite you again to join us on Wednesday, the 5th of May, when Dr. Ramachand's topic of discussion will be, will the COVID-19 vaccine help long haulers and asymptomatic persons? Until then, this is Dr. Varma Rambaran reminding you that we are our brother's keepers. And to remain safe, we are to mask, distance,